From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Welcome to the JAMA Psychiatry Author Interview podcast. I'm your host and web editor, Dr. John Torous. Today, we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Placebo Treatment, a systematic review and meta-analysis of differential effects across 9 psychiatric disorders. We're about to be joined by the corresponding author of the paper, Dr. Tom Bschor, MD, in the Department of Psychiatry and Psychotherapy, University Hospital, Technical University of Dresden in Dresden, Germany. The foundation of many clinical trials in psychiatry is measured against a placebo response group. How well does, say, a new treatment fare against one in which that active ingredient is removed? Far from just an academic interest, the placebo response and question of what is an appropriate placebo control group is a very important topic that even now impacts, say, digital treatments. What do we really know about the response to placebo arms in research studies, and what type of effects to placebo responses can really be expected? To find out, we'll explore the results in this brand new study just out in JAMA Psychiatry. So it's with my pleasure to welcome Dr. Bschor, and your paper's on the placebo effect and response. So let's start by defining what is the placebo effect and response.
In psychiatry, we typically see improvements also in the placebo groups. People get better. And this is not all about the placebo effect in the strict sense. The placebo effect in the strict sense means the suggestion of hope, because you might get the active treatment if it's randomized and double-blind, the induction of hope and conditioning effects. These make the placebo effect in the strict sense. Conditioning effect means, well, we all have experiences that headache relieves when we take a pill, and that makes conditioning effects. But there are additional factors leading to improvement in the placebo groups. Many of the psychiatric disorders follow an episodic course, and that means they can get better just by time. And we have contextual factors in studies, meaning attentive study personnel, compassionate care, supportive conversations, or psychoeducation. And that altogether, we called it the placebo response and not the placebo effect, to have that all together.
As you just explained, there's a lot of things that go into the placebo response, why someone may feel better in a different study or in a treatment. Is the placebo response, from what you knew before the research, is it the same or different across different disorders, say across depression or people with anxiety or people with schizophrenia?
Well, I think it's very reasonable to assume that there are differences. So if we go back to the factors we've just discussed, some of the disorders are more episodic, others are more chronic. The ability to develop things like hope and confidence is impaired in different ways across diagnosis. And then, of course, we assume that there are different amounts of biological factors or psychogenic factors involved in the conditions. And of course, we think that psychogenic factors are more responsible to placebo effects. So it's reasonable to assume that there are differences, but up to our work, there was no comprehensive comparison across the disorders.
That makes a lot of sense. These are very different disorders. We know they have different medication treatments and different therapies. So it makes sense that the placebo response may be different across them as well. And I think you alluded to it, but why do you think it's most important that we understand how the placebo response is different across it? So we know this may exist, but why does it matter?
First of all, it will help us in treating our patients, in guiding our patients. First of all, how important is it to start an active treatment right now, or can we wait? That makes a difference if disorder typically gets very much better in a placebo group or not, or if it even would get worse. And the second thing is it helps us in interpreting studies, especially uncontrolled studies. We still have many results from uncontrolled controlled studies, many reports on that. And we have always to keep in mind that what we see might have happened only with placebo as well. So if things get better just by time, that it's not sure that this has to do with any kind of treatment that happened. But even in controlled studies, it's important to see how much was the placebo effect and what is the additional effect of the active treatment. So it's quite helpful to understand the differences between the placebo response across disorders.
And you pick 9 conditions to review this across, including major depressive disorder, and you have unipolar recurrent or single episode as MDD, mania, schizophrenia, obsessive compulsive disorder, OCD, attention deficit hyperactivity disorder, ADHD, general anxiety disorder, GAD, panic disorder, post-traumatic stress disorder, PTSD, and social phobia. You note that you are going to assess the placebo response across these common psychiatric conditions. And of course, we know there's a lot of research on these common psychiatric conditions. There's a lot of placebo control groups. How did you set up the study so that you didn't have to look at every single paper ever written across humanity?
You are absolutely right. We wouldn't have been able to go through every single placebo-controlled study ever conducted with these 9 disorders. So this would not be feasible. We decided on a 2-step approach to pick out the end 10 high-quality recent RCTs per each diagnosis, totaling 90 RCTs. And 2-step approach was that we first were systematically searching for the most recent systematic review on the respective diagnosis. So we did that into databases with a clear protocol, and then we came out with 9 recent reviews. And then we used these reviews because they already screened the literature. They already did the systematic search so that we didn't have to do that again. And in addition, in every well-conducted systematic review, of course, all included studies are rated by quality. They all use in the Cochrane risk of bias tool. And we use that rating to pick out the 10 RCTs with the highest quality for each of the 9 diagnoses. And that's how we ended up with 90 placebo groups, which were the basis for our analysis.
Which is still a large number, 90 studies. This is still tremendously large, but I think that's a very clever way to take, again, what could be every single study in the universe and bring it down into a manageable set. So now that we know how you found the papers and we're looking to understand the placebo response in these common psychiatric conditions, what did you set out as the main and secondary outcomes that you were looking for? So we won't talk about the results yet, but what are you looking for as the main and secondary outcomes as you begin this?
Well, the main outcome, of course, was how good do the study participants improve under placebo treatment. And then the next methodological problem arose because for each diagnosis, other rating scales, psychopathological rating scales are used. Even in the same disorder, different rating scales were used. So we had to standardize the results, and what you use in systematic meta-analysis is standardized effect sizes. And because we did not took the comparison to the active arms, we just ignored the active treatment groups, we had to use pre-post effect sizes, standardized pre-post effect sizes that makes them comparable irrespectively of what kind of rating scale was used. And then we had to build pooled standardized pre-post effect sizes for each of the 9 diagnoses. Therefore, we used random effects meta-analysis. And that was our main outcome. And secondary outcomes, the most important probably was the CGI, the Clinical Global Impression Scale, which is a scale which can be used in every diagnosis, which is global, as the name says, and it's a very valid scale. And that was just to confirm our results, because then we could use the same scale across all 9 disorders. And in addition, we also looked on dropout rates, but we haven't analyzed them up to now. This will be subject to a follow-up publication.
How many papers did you and your team end up screening, and how many were included in the final review?
Well, in the first step, we made a systematic search for systematic reviews, as I told, and we ended up in 3,573 hits, and we went through them to pick out the most recent high-quality review, 9 reviews for 9 diagnoses, and that was where we ended up.
A lot of work you and your team did to screen that down. Let's talk about what was the main outcome of it. You built us up to this point, so share with us what is the most important thing you learned.
The first outcome was that in all diagnoses, there was an improvement even in the placebo groups, which was significant and not explained just by random effects. So all 9 disorders improve under placebo treatment. Second was that improvement, at least in most of the disorders we looked at, was of considerable magnitude. And the third, in fact, was that the improvement in the placebo groups varies significantly among the disorders. So it's not the same. And I'm sure everybody wants to know what were the disorders with most improvement, and that was major depressive disorders and generalized anxiety disorders. They showed the greatest improvement under placebo. And you can say we have a middle group that was panic disorders, ADHD, and PTSD. And then we have 4 disorders with still considerable improvement, but less than the others. That was social phobia, mania, obsessive compulsive disorder, quite interesting, rather small improvement under placebo, rather small placebo response, and schizophrenia.
We'll come back to some questions on why different disorders had it, but I think your 3 main points I want to review are that there was improvement in all the groups. That improvement was of significant magnitude, but it varied across different disorders, and depression, major depressive disorder, and anxiety were definitely the highest ones. And again, we'll come back to talk about some of those nuances in a moment, but let's also talk about your outcomes related to the clinical global impression scale. As you said, it's a nice number. As you said, it's global. We can use it across all conditions and illnesses. So what did you and the team discover there?
47 out of the 90 RCTs we analyzed used the CGI. So it was not all RCTs, but at least a little bit more than half of the RCTs. And our results from the main analysis were confirmed with regard to the CGI, not major depressive disorder, but generalized anxiety disorders was that with the highest placebo response, and mania with the least one. But it confirmed our primary results.
I encourage everyone listening to read the paper. There's even so many more fantastic tables and details there. I know, Dr. Bschor, you had a regression model. What were the results around that regression model?
The disorders, of course, differed with regard to important variables. For example, in generalized anxiety disorder and in major depressive disorder studies, typically there are more female participants than, let's say, in schizophrenia studies. That's quite important. The study duration is different between the disorders. For example, studies in mania are typically short, 3 weeks, but in anxiety disorders up to 12 weeks. And we were interested if the likelihood to receive placebo might influence the placebo response, because we also have 3-arm studies or 4-arm studies where the likelihood to receive placebo is not 50%, but only 33%, and so on. So it could be possible that the differences that we found are not due to the respective illness or to the diagnosis, but to the differences in age of the participant, gender, sex, study duration. And that's why we first did bi-variable regression analysis to find possible single influences. And there it came out that possibly gender or sex might influence the results, study duration, and the probability of receiving placebo, beside, of course, a diagnosis. And then we put those which we found into the multi-meta regression, and then only gender or sex remained statistically significant, meaning that the differences we found between the different disorders cannot be explained by study design variations only.
Earlier, you said of one of the three results that were improvements in all groups, but were the largest improvements with the placebo response, especially for those with diagnosis related to depression and anxiety. Why do you think this is so? So again, we'll speculate. I realize the study is not designed to answer this question, but based on your expertise, why is this happening?
As you said, we cannot answer that from our data, but of course you can have a hypothesis. First of all, affective disorders as depression typically follow an episodic course. So just time leads to improvement. And of course, we see time goes by in the placebo groups. And then if we think what constitutes psychotherapy for depression, very important aspects of psychotherapy, regardless of the specific type of psychotherapy, are things like interpersonal support, psychoeducation, inspiring of hope, and explaining medical concepts. And that typically happens in clinical studies as well, and of course also in the placebo groups. And so this is delivered to the patients, and we know that people with depression respond to these factors. So this is one of my explanation. And for anxiety, at least, these components of psychotherapy are at work as well.
That makes sense as a hypothesis. And as you said, we won't know exactly what's happening yet. But related, you also had results that showed that there was a smaller placebo response in conditions like schizophrenia or obsessive compulsive disorder or mania. If we had to speculate again, why do we maybe see a smaller response in these conditions?
Schizophrenia has, unfortunately for many people, an unfavorable prognosis, and that's what we possibly see in the placebo groups. And maybe study participants do not respond as well to interpersonal support and things like attentive study personnel. If one has in mind that schizophrenia can impair interpersonal functioning, it can reduce the attention to communication, it can distort reality perception, and it can limit insight into the disorder. And that might be factors that reduce these non-specific effects in studies. But in addition, we believe, or most researchers believe, that schizophrenia is a disorder with a rather high biological component and rather small psychogenic component, and that might be why it cannot be that much affected by placebo.
These are complex questions that we don't have answers to, but it's important to know at least a degree of placebo response we can expect in various trials. And perhaps related to that, how should clinicians hearing about these results use them to inform, say, how they understand new treatments or how well that different treatments can work?
Well, first of all, I think our results underline the importance of a control group in clinical studies. Without a control group, for example, in depression research, just a pre-post comparison does not say anything, because we see that even with placebo, there's a very huge improvement. So we should not rely on case series and uncontrolled studies, but even in controlled studies, it's important to look at the difference between placebo and the active component and not just at the active arm.
What aspects of these results can we use to make current treatments even more effective for patients?
I personally believe that for many drug treatments, contextual factors are very important. They make the drugs work better. We know this best from antidepressants and from treatment of depression. Just handling out the pills and say 1 a.m. and let's meet again in 6 weeks minimizes the effect. But if you surround it by good contextual factors, explaining, giving hope that the medication will work, that can augment the effect, and that is something that we can learn from these results.
To conclude, of course, a placebo response does not mean psychiatric treatments are not effective. We'll make that clear. These are effective treatments. But as you said, it does mean that we need to carefully assess claims and look at the quality of evidence that we judge treatments against. What comes next in this world of placebo response research?
Well, we cannot differentiate what is the placebo effect in the strict sense and what are contextual factors. And therefore, it would make sense to have 3-arm studies, an active arm, a placebo arm, and the third arm with no treatment at all, with no placebo, so that there is no placebo effect in the strict sense. We nearly do not have these kind of studies at all, at least in psychiatry. And in addition, it would make sense to study the contextual factors by varying them and comparing them to get most out of our treatments if we put them into a good frame.
That's a very intriguing and exciting idea to leave on. So again, I'm John Torous, and I've been speaking with Dr. Bschor about placebo treatments, a systematic review and meta-analysis of differential effects across 9 psychiatric disorders. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or refer to JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thanks for listening.